All right, it's part 2 of the kidney disease lecture. There's still plenty of other stuff for you to concentrate on and learn in the slide deck and in the module. Things like glomerulonephritis and several other things. The other information that is in the lecture and in the textbook is still important, but I want to focus our attention on the things that you're going to be encountering every single day in clinical practice: chronic kidney disease and, to a lesser extent, acute kidney injury. So let's talk about those things, starting with CKD. We define CKD by the patient's glomerular filtration rate, or GFR. Patients who are at risk for kidney disease, who have a GFR greater than 90, are people like hypertensives and diabetics early in the disease. But we want to identify them early so that we can make sure that we take preventative measures to preserve their kidney function as much as possible. Stage 2 CKD is a GFR 60 to 89. Stage 3 is where we start to get more nervous, right? These are patients who really have to be identified because they are at higher risk for further deterioration. So we subdivide this stage into A and B. So stage A is a GFR 45 to 60, and stage B is the more advanced form that's 30 to 44. So these are patients who need to be identified so that we can keep their renal function from deteriorating. Stage 4 is somebody who we're beginning to look at dialysis for, right? It's not anytime soon, but we're starting to have that discussion with patients and thinking about how we can proceed. Of course, we're trying to preserve as much kidney function as possible, but it becomes more difficult because these patients get hyperphosphatemic, they get metabolic acidosis, they become hyperkalemic, and those are things that cause us to need dialysis in some cases. Well, in any case that we have uncontrollable versions of those things, we're going to end up having to dialyze these patients more quickly. Stage 5 then is end-stage renal disease, or ESRD, and that is a GFR less than 15. Their urine is just very dilute, doesn't have all the stuff in it that it needs to get rid of it from the body, and these patients develop symptoms of uremia. They often have severe, very difficult to control hypertension and hyperphosphatemia. We're going to talk about why those things are so important soon. Now, what are the causes of CKD? Well, you heard me mention diabetes and hypertension. That makes up 87% of all CKD in this country. 87%. It's ridiculous, right? So these are patients who we need to identify quickly, make sure that we have them treated with the right medicines and good blood pressure control to slow down the progression of their kidney disease. Other causes of CKD are glomerulonephritis, interstitial nephritis, genetic problems, some autoimmune disorders like those that we've mentioned, glomerulonephritis being largely an immune problem. So those are the causes of CKD. Now, this slide I really like because it specifically shows you what the major kidney malfunctions are. So the kidney is in charge of these 5 things, and sodium balance is the first thing. So we rely on the kidney to get rid of sodium, and along with sodium goes water, right? Well, when the kidneys don't work, then we end up with sodium retention, and therefore, because sodium and water go together, volume overload. All right. We have to address that oftentimes with diuretics, but carefully, because diuretics will perhaps further reduce kidney function as well. So we have to be careful about that. Potassium excretion happens in the kidney. That's the only way for your body to get rid of potassium. And you know that potassium levels that are above 6 are deadly, right? So we have to have a way to get rid of potassium, and that's why this particular kidney function is so important. Acid excretion also happens. We talked about that in the acid-base part of this module. And so we end up having to give these patients sodium bicarb for a while. At some point, that no longer is effective, and we have to use dialysis. Calcium and phosphate balance is very important, because we know that when these patients get to dialysis, the higher their phosphate levels, the more likely they are to die. And so survival is inversely related to phosphate. One other thing then is erythropoiesis, right? So erythropoiesis happens, or erythropoietin is secreted in response to hypoxemia that's noted at the glomerulus. And there's other tissues in the body that participate in this process, but principally it's the kidneys. We don't really know where it's made. We haven't really found that cell, but we know that people with kidney disease are often deficient. In the later stages, they're always deficient in erythropoietin. So those 5 things that we discussed there, those are reasons that we need to start dialysis. So patients who we can't control the potassium, we can't control the acid-base balance, we can't manage their hyperphosphatemia, we can't manage their volume status. Those are reasons that we would start dialysis. Another indication for dialysis, though, is symptoms of uremia, and there are a whole bunch of them here. So these symptoms of uremia, or uremic syndrome, are another indication for dialysis, because these things can't be fixed until you get better excretion of waste products from the kidneys. So how do we manage chronic renal failure? Well, very briefly, you know that when we don't manage it, we end up with volume overload causing pulmonary edema, pleural effusions, pulmonary infections, pneumonitis. All those things happen with pretty decent regularity and frequency in patients with end-stage renal disease. They also end up with gastrointestinal alterations like GI bleeds, anorexia, GERD is a major problem. Constipation is also an issue. Again, that volume status. We have patients with neuromuscular problems like seizures and tremors and sleep disturbances. And then we also have a tendency to bleed. And then there's other things as well: musculoskeletal alterations, integumentary alterations. The skin breakdown that can happen in these patients is pretty common. Managing their dietary intake to restrict fluids and sodium and potassium and phosphate, all very important issues. The anemia that happens in CKD, I alluded to that earlier, but it's not only because of erythropoietin deficiency, but also the RBCs just don't survive as long in this hostile environment. With higher potassium and sodium and volume status, and the red blood cells tend to get beat up more. They don't respond well to the persistent acidemia, and all that stuff together works to the detriment of RBC survival. So they don't last 120 days anymore, it's less. There can also be blood loss because of the bleeding tendency that happens. And then, of course, there's a host of other reasons that anemia can happen. I mentioned earlier that we really want to manage the phosphate levels. And this is a great visual representation of risk of death on the y-axis in relation to the serum phosphorus levels. And so you can see that the higher the phosphate levels, the worse the survival, or the higher the risk of death is, as opposed to when we manage that serum phosphorus level down in the 3 to 5 range. So we aggressively manage phosphate levels to ensure that our patients do better. So that's CKD. I want to talk to you now about acute kidney injury, because that is something that we encounter quite a bit in the hospital, and to varying degrees, right? Sometimes it's just a little bit. We bring somebody in who has heart failure, and their creatinine is a little high because they have some pre-renal cause. They're not getting enough blood to the kidney because of the heart failure. And so we give them some diuretic and their creatinine goes down. And then we continue to give the diuretic because we love the fact that they're losing fluid and that they're not in heart failure anymore. And for whatever the reason, we keep their diuretic on too high of a dose, and then we see the creatinine go up again. That's because they're pre-renal again, but from the other end, right? Because they have too low a blood volume and they're not able to get enough pressure head to get to the kidney and the glomerulus to get rid of waste products. So acute kidney injury is something that we deal with quite frequently. It affects 5% of hospitalized patients, but when we see it, it has a 50 to 80% mortality. That's incredible, right? It is a very, very important thing for us to avoid, and we have to work hard to do it. So there are 3 classifications of acute kidney injury. It can happen because of pre-renal causes, that is, all the stuff that happens before the blood gets to the kidney, or the things that prevent the blood from getting to the kidney. There's intrarenal causes, or sometimes we just say renal causes. And those are acute tubular necrosis primarily from ischemia or nephrotoxic drugs or nephrotoxic dyes, like contrast dye. Those things can cause necrosis of the renal tubules, and those cells slough off and they fall into the urine and they plug up parts of the nephron and cause a mess. And then there's post-renal causes, and these are obstructive causes. We like if I had to pick one of these to manage, I would say that post-renal is the easiest to manage because we just have to relieve the obstruction. We'll talk about that in a minute, though, because it's not always that easy. You learned in undergrad that there's 3 phases of acute kidney injury. There's oliguric phase, the anuric phase, and the polyuric phase. We don't always have the anuric phase. Did you ever notice that when you had somebody with acute kidney injury? They don't always have an anuric phase, and you're thinking to yourself, well, I learned this in college. Why is it not the case here with this patient? Well, 10 to 20% of the time, that doesn't happen. So we use this rifle system to define, the types of acute kidney injury. So we have people at risk. That's the R. So people at risk for acute kidney injury. So like that patient with heart failure who I mentioned, who comes into the hospital and we're going to diurese them, they're at risk for acute kidney injury because we're messing with their fluid and volume status, right? They may also not have normal kidneys to begin with. So those people are at risk. There's injury that happens. There's the failure part, there's loss of nephrons, and then there's end stage where they end up needing dialysis. So we don't talk about the rifle classification system, but we think about it when we're thinking about severity of disease. So there are 3 stages of acute kidney injury that we have noticed over the years. These stages include a change in the creatinine level, and the resultant change in the urinary output. So an increase of 0.3 milligrams per deciliter or more than 1.5 to 2-fold baseline change in creatinine is stage 1 acute kidney injury. Okay? And the urine output goes down to about 0.5 ml per kilogram per hour. And that's over more than 6 hours. It can't just be, they get a little dry, we give them a little fluid, and although their kidney function went down or their urinary output went down for an hour, it comes back up the next hour after they get some fluid. That's not what we're talking about. We're talking about persistent for more than 6 hours. So you're the nurse, you're going to be the first person to notice that. Stage 2 then is an increase of 2 to 3-fold of the creatinine, 2 to 3-fold from baseline, and that further reduces the urinary output for a longer period of time, for at least 12 hours. And then stage 3 is a 3-fold or 4 milligram per deciliter rise in the creatinine and persistent oliguria, reduced urinary output for 24 hours, or anuria for 12 hours. Okay? At this stage, we have to implement renal replacement therapy, whether it's CRRT in the ICU or whether it's dialysis or what have you. They need renal replacement. So I mentioned the 3 mechanisms of acute kidney injury. There's prerenal, intrarenal, and postrenal. Let's go through and talk about each of them. The prerenal is caused by something not getting enough pressure head or enough blood to the glomerulus. That can mean that it can be because you're hemorrhaging to death and you have hypovolemic shock and you're not getting enough blood to the kidneys. It can be severe dehydration where you're not getting enough blood to the kidneys. It could be burns, right? Because burns cause you to lose a ton of fluid. Remember the Parkland formula and the ridiculous amount of fluid you have to give in a 24-hour period? I mean, it's insane the amount of fluid that these patients get. Well, that's because you lose so much through burn tissue that we have to replace it urgently. So those are 3 major etiologies of prerenal. There can be a relative decrease in the circulating volume. So think about distributive shocks here. Those are septic shock, neurogenic shock, or anaphylactic shock. In those cases, there's enough fluid in there if the vasculature were constricted enough. But there's this massive vasodilation that happens in distributive shock, and that means that there's relatively not enough fluid. So we got to tank those patients up, give them enough fluid volume in the intravascular space, and make sure that the blood flow gets to the kidney. Another one is third spacing or edema. I don't know if you've seen patients who have anasarca, but they have so much fluid that I've seen patients with 100 pounds of fluid on board. And they have 4+ edema in the abdominal wall and all the way down their legs, and they're just full of fluid. Well, that fluid ain't no good to the kidneys because it's it's not in the vascular space. And so that blood can't get to the kidneys or that fluid can't get to the kidneys to be diuresed and participate. Renal artery stenosis is another reason that you can have prerenal acute kidney injury, because if the renal artery is narrowed enough, you can't get blood to the kidney to get to the glomerulus to make urine, etc. So there are different reasons that people can have renal artery stenosis. It can be something that they're born with, which tends to appear in young women. And there's the old man form, which is atherosclerotic. But you've read about those as well. Now, don't forget that there are drugs that can affect pre-renal states as well. We talk about NSAIDs, and it's commonly believed that they're bad for your liver. Well, that's true, but they are dreadful for your kidneys. So stop letting your parents and grandparents eat ibuprofen all day long. They are one of the other leading causes of kidney failure and the need for dialysis. They are just bad for your kidneys. The reason is that they cause efferent, that's the arteriole on the other side of the glomerulus, right? After it's already gone through the glomerulus, the blood flow. The efferent arteriole is the one that takes the blood to the convoluted tubules and the loop of Henle. ACE inhibitors and ARBs are good for your kidneys because they provide afferent vasodilation. What does that mean? Well, the afferent arteriole is before on this side of the glomerulus, and that means it limits blood flow to the glomerulus. Well, that doesn't sound like it's good. Well, in fact, when we start ACEs and ARBs, we see a little increase in the creatinine, maybe a little increase in the potassium level, and we expect that. But as kidney function worsens, it's awful for those people to be on ACE inhibitors because they can develop worsening renal function and hyperkalemia. How does that happen? Because of this afferent vasodilation. So to prevent kidney disease in diabetics, for instance, we love ACE inhibitors and ARBs because they decrease the amount of blood flow that gets to the glomerulus. But if your kidneys are already sucking wind and having trouble getting rid of all the stuff, like potassium, for instance, then it's maybe a bad idea to have people on ACE inhibitors and ARBs. Okay? I hope that all makes sense to you. ATN then is acute tubular necrosis, and it's exactly what it sounds like. Acute means it happens, right now. Tubular means that it affects the tubules, the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, the collecting duct. All of those cells that line those start to slough off and die, and they can plug up things in the urinary tract, at a microscopic level, and make it hard for the urine to get through. So that is the principal problem at work in ATN. And when I said that those cells are falling off, that's cast formation. They look like casts of cells. They look like the remnants of cells. Well, they are. That's exactly what they are. And they can gum up the tubules and cause increased tubular pressures. And that produces renal failure. Okay? There are 3 phases of ATN. There's the prodromal phase where the injury has occurred. The BUN and creatinine go up. Then that eventually leads to lower urine output. And then there's a post-oliguric phase where there's a fluid volume deficit, but the labs begin to normalize then. Now, how is it that kidney function diminishes with persistent hypertension? Well, this is a little illustration of that. So when we have systemic hypertension, that can cause renal injury and loss of nephrons. And when that happens, we get increased angiotensin II circulation, which, by the way, worsens systemic hypertension. And how does that happen? Well, through this mechanism. There's glomerular capillary hypertension. There's increased glomerular permeability and filtration. That means that proteins leak into the urine, which is bad news. These big holes allow these giant protein molecules to move in. There's increased tubular protein reabsorption, and that causes more inflammation and fibrosis to occur, which causes renal scarring. which, by the way, worsens systemic hypertension and starts this cycle in a downward spiral. The only thing I want you to know from this is that the GFR is inversely related to the plasma creatinine. Okay? So it's curvilinear. When the when the GFR is really high, like at 120, the creatinine's 1 or whatever, this is the best situation, right? As the GFR trails off, the creatinine goes up. But look, you can lose a lot of renal function before it affects your creatinine too much. So you can go from 120 down to 90 and have your creatinine only doubles, right? But look what happens next time it doubles. Well, we're going from, say, 90 here to doubling your creatinine at 60. So from 60 to 90, that's doubling your creatinine. Now let's double it again. We go to 8. Look how bad your kidney function is now, right? So now we go from a GFR of 60 down to 30, and our creatinine has again doubled. So this means that it's hard for us to use the serum creatinine to really gauge the GFR when the creatinine is normal and above 90. It's very hard to know where we are on that. But as kidney function worsens, it becomes a little easier because you're in this sweet spot of the curve. Now, how do we differentiate between prerenal and renal acute kidney injury? Well, that's where certain tests like the fractional excretion of sodium comes in, or the FENA. If the FENA is between 1 and 2, it doesn't really help us very much, but when it's less than 1, that suggests prerenal, and when it's greater than 2, that suggests a renal cause. What is the FENA? Well, that's a function of the urine sodium and the plasma sodium, and then you plug it into an equation and you see what the fractional excretion of sodium is. All right. I don't intend for you to memorize that, but it's a good thing for you to look up and be interested in. Other things that are useful are the urine-specific gravity. So a prerenal is making normal urine, right? But a renal cause means that your urine is dilute. And so this is where you get a lower urine-specific gravity, 1010 to 1020. But when you have prerenal, the urine is normal. It's just deficient, right? There's a lower amount of urine being made, but it is just as potent urine as it would be if you had good blood flow to the glomerulus. So higher urine-specific gravity means that you have more concentrated urine. Lower specific gravity, 1010, means that you have very dilute urine. Okay. The urine osmolality, which is another calculation based on a 24-hour urine specimen, is useful in differentiating these two. And the BUN to creatinine ratio, there's so many things that go into this that I just haven't found it useful over the past several years. But one thing that from the urinalysis that we can see is useful is the urine sediment. So you should have few urine casts. You should have very few casts in the urine in prerenal. But remember, we said that the thing that's going on in ATN is that the cells are dying in the tubules and they slough off and fall into the urine and sometimes gum up the system in the meantime. But we see those casts when we look at urine, right? So we get a urine specimen, a urinalysis, look at it under the microscope, and we can see tubular casts and RBCs and white blood cell casts, etc. Okay? Then there's postrenal acute kidney injury, and as I said, this is the most amenable to treatment because think of one of my first experiences as a nurse was working in the emergency room, and I saw an older gentleman come in with urinary retention, hadn't gone to the bathroom in a couple of days. Urology came, they in a very brutal and awful way put a Foley in him. Now, they had a lot of work to do with filiforms and followers, and it was brutal to watch. But in any case, his urinary output picked up again because they relieved the obstruction. His obstruction was from BPH, right? When women have post-renal causes of acute kidney injury, it's because of pelvic tumors 100% of the time, unless proven otherwise, right? So because there's a shorter urethra, there should not be any obstruction to urine flow in women. But when there is, it's because of some tumor growth. So I had a patient a couple of months ago. It was a woman who came into the hospital and had acute kidney injury, and on exam, you could feel her bladder was enormous. She gave a history of not having gone to the bathroom for a day or so, and she had abdominal pain, pelvic pain, all that. And it turns out that she ended up having cervical cancer was the cause of her urinary obstruction.